No, fibroids are very common. It's affect quite a large number of patients, depend on their patient ethnicity, age, and other reasons. So not all fibroid need to be treated. The fibroid cause heavy period, which is usually affect the endometrial cavity or muscles of the womb and quite large fibroids, or in fibroid that cause problem with fertility or miscarriages or preterm birth, or the fibroid cause significant pain or bladder symptoms need to be removed or treatment. Not all small fibroids need treatment. For example, if a fibroid is around 3 centimeter, incidentally found a fibroid, we don't need to do any treatment at all. We do not need to monitor at all because the risk of fibroid to be a cancer is very uncommon, especially if it's a small multiple fibroids compared to one fibroid, which is around 8 centimeter, that's need monitoring or treatment. So the non-surgical treatment, which is hormonal treatment, ideal for patient with small fibroid and symptom can be controlled. So just imagine a scenario, a woman at 45 have heavy period and the fibroid is 3 centimeter. Those patients are eligible for either progesterone only hormonal treatment such as Mirena coil or Mirena hormonal pill. But the ideal choice will be, at present, there are GnRH oral antagonist tablets available. There are 2 brands available at present, but all over the world there are another 4 different brands available, which is relatively new. Those tablets actually stop the period, at the same time give hormonal replacement, so patients do not feel hot flushes. But traditionally, for example, if it's a woman around 48, have a 5 centimeter or 4 centimeter fibroid and doesn't want a hysterectomy or hysterectomy high risk, we offer a GnRH analog injection, which is called decarpeptide injection, which is actually stopping the signal from hypothalamus to the ovary to stop signals. And so ovary do not produce estrogen and progesterone, and patient temporarily become menopause. To avoid hot flushes and menopause side effects, we give hormonal replacement therapy, usually called Livial. But sometimes patients who have high risk of Livial with blood clots in the legs or blood clots in the lungs, then we might put a Mirena coil and estradiol patches. So those are the 2 very effective treatment choices, such as progesterone treatment or GnRH analog antagonist oral tablet or GnRH analog injections. So the surgery removal of the fibroid depends on the location of the fibroid, patient age, her fertility desire, and her cultural beliefs and what she prefers. So for a woman, for a young girl at 22 or 23, I will not go for a fibroid surgery at 22. But if he is 28 and the fibroid affecting the cavity of the womb, or if the fibroid more than 4 centimeter, I will either remove the fibroid through hysteroscopy resection, or I will do a laparoscopy and or open surgery called myomectomy and remove the fibroid. We're trying to remove the fibroid that's more than 4 centimeter, affecting the muscles part of the womb, or any fibroid that affect the cavity before fertility treatment or patient who is difficulty in conceiving. And we do sometimes take any fibroid that affecting the cavity before IVF or patient with miscarriages. We usually do hysteroscopy resection of the fibroid, which is quite effective and safe, but sometimes there's a risk of perforation of the uterus. The laparoscopic myomectomy is good for patient who has 1 or 2 fibroid, quite around 5 to 8 centimeter. If it is more than 5 centimeter fibroids, but more than 3 or 5, a robotic myomectomy or open myomectomy is better than the laparoscopic myomectomy, which you can see the evidence, especially we published from the large number of the literature review. Uterine artery embolization is very well-established procedure. It's done by the interventional radiologist, not by the gynecologist. But gynecologists should ideally select the best patient for embolization, because embolization is not ideal for every fibroids. For example, if a pedungulated fibroid, which is outside the womb, or if the fibroid within the cavity, submucosal fibroid, the embolization doesn't work. Embolization should not be done on patients who are planning to have children, because embolization causes necrosis and causes recurrent miscarriage and difficulty in implantation. So embolization should be an ideal choice on women who completed the family and mainly suffering from heavy period rather than pain with the fibroid. And the fibroid on the MRI, we do MRI before embolization, and should be evaluated by the gynecologist and radiologist and see whether which patient the MRI suggested that fibroid treatment with embolization ideal choice. Because embolization basically indirectly means killing of the fibroid at the cellular level and causing necrosis. One of the complications of the embolization is acute severe pain, and some patients may have chronic pain. So the embolization is ideal for heavy period, fewer fibroid, myometrial fibroid, and ideal for patients who the laparoscopic hysterectomy is not ideal choice because of the obesity or cardiac problem or patient choice not to have hysterectomy. But embolization is a well-established procedure, but compared to laparoscopic hysterectomy, embolization still need around 5 to 20% may need further surgery, and around, depend on patient perception and how the pain was before surgery intervention, around 5 to 20% may have chronic pain. So those patients need much more discussion by the gynecologist and the interventional radiologist. So myomectomy means removal of the fibroid. If it's a small removal of the fibroid done through the hysteroscopically, the risk is mainly the fibroid coming back. Other than that, it doesn't affect fertility mainly. But most of the time, the hysteroscopic resection of the fibroid should not be encountered if the large muscles fibroid in the left, because that means the hysteroscopic resection is not effective and create a future problem with the difficulty in removing the rest of the fibroid. If we open up and remove the fibroid, which is the best choice for a patient who is planning to conceive and have more than 3 fibroids, and most of the fibroids are more than 8 in the size or the number, the open myomectomy or laparoscopic myomectomy has risk such as adhesions, recurrence, and affecting the fallopian tube function. So most of the women should have discussion about future fertility. So in our practice, we ask the GPs or family clinician to refer to fertility clinic while we are planning for myomectomy. So after the myomectomy, we will ask them to try to conceive, but while waiting for the myomectomy, the patient will have blood done called AMH to assess the ovarian function. Patient partner will have done a semen analysis to make sure these are normal. During the myomectomy, we will check the tube function before or after, if it is possible. Because after the operation, we will say they can try to conceive after around 3 to 6 months. If they are trying to conceive for 6 months, and if they are not conceiving after 6 months, or some patients who are aged more than 35, after myomectomy, we will refer to fertility treatment such as IVF. Because if we delay that, number one, the fibroid may come back. Number two, our studies and our reviews shows if the patient doesn't conceive by 6 months after the myomectomy trying for pregnancy, the chances falling down after 6 months. But we don't want this patient waiting for natural conception and the fibroid come back. So before IVF, we sometimes do a camera test into the womb and make sure the cavity of the womb hasn't got adhesions, needs separation. Sometimes we separate the adhesion after myomectomy in 3 months' time before she go for fertility treatment. So we have to discuss before myomectomy about fertility and make sure patient have a good ovarian reserve, good fallopian tube function, and partner semen analysis normal as much as possible if it's possible to confirm.